everyone. Thank you, and thanks to the committee for organizing this event, first of all, and for letting me present the data from the work that we do in our lab in Rome. And I would like to start from this picture here. Some of you may have recognized it. This is an osteoclast from FD bone biopsy. It is stained with an anti-MMP9 antibody. And it is not only the main character of this presentation, but actually the main character of the last 7 years of work in our lab. I don't think I have to introduce the human fibrous dysplasia anymore. So in my presentation, I will focus on the mouse model that we have generated some years ago. This mouse model harbors a GS-alpha R201C mutation that is under the control of a constitutive and ubiquitous promoter, that is the elongation factor 1-alpha. This means that the mutation is always expressed in all the cells of the body, and despite the ubiquitous and constitutive expression, embryonic development is not affected. We didn't find any changes in embryo. But the disease, FD disease, develops postnatally, exactly like the human disease. And it develops as a monostotic disease around 4-6 weeks of age. Usually it starts in tail, that is the bone segments that is always affected in these mice, but then develop as a polyostotic disease. Already at 3 months of age, we have a polyostotic disease. And actually, when the mouse gets old, we have almost a panostotic disease with a lot of bone segments affected, as we can see here in this 5-month-old animal. I reported the frequency of the affected skeletal segments. So we have FD lesions in axial skeleton, in the appendicular skeleton, in the skull, in jaw bones. So this is how it presents. And it is also good to see that the histopathological features of the disease are completely reproduced in this mouse model. So we have the deposition of fibrous tissue with a lot of osteoclasts that are there, and then we also see osteomalacia and woven bone in this bone section. As you may know, bone resorption is one of the major morbidity cause in fibrous dysplasia, and it has been demonstrated that the pathologic tissue express some of the most common osteoclastogenic factors, such as interleukin-6 and rank ligand. And we've also demonstrated that mouse FD express rank ligand in the FD lesion. And bone resorption is one of the target for the therapeutic strategies that have been developed in fibrous dysplasia. I will not say anything else about bisphosphonates. For instance, here, the clinical trial with zoledronate didn't show any improvement in the bone disease. And we've also demonstrated that in mouse, bisphosphonates are ineffective on the tissue pathology, but actually, in addition to this, treatment with bisphosphonate leads to the formation of giant osteoclasts that were observed not only in mice, but actually also in a biopsy from an FD patient that was treated with pamidronate. So we should pay attention to that also. Conversely, the rank ligand inhibition has been demonstrated to be an effective strategy. We have demonstrated in 2019 that if we inhibit rank ligand in the mouse, we can stop the disease progression and prevent the disease development in non-affected skeletal segments. But more importantly, we observed that we could convert the fibrous tissue into mineralized bone. And also, Dr. Zhao will present something later in 2022, show the same in another mouse model, and more recently, as Dr. Boyce we heard from Dr. Boyce that they demonstrated the safety and efficacy of denosumab for human patients. However, the problem with the anti-rank ligand treatment is its discontinuation because it leads to the disease rebound, and this was true also in the mouse, where after 1 month from the interruption of the treatment, we could see new lytic lesions formation, and with a rebound of osteoclastogenesis on a tissue level. So, keeping this in mind, we start seeking some strategies to prevent or delay the disease rebound associated with the anti-rank ligand treatment discontinuation. And what we thought is to first treat the mice with the anti-rank ligand, that is a murine analog of the denosumab, in order to not only eliminate all the osteoclasts there, but also to allow the bone formation and mineralization of fibrous tissue. At that point, we thought to administer zoledronate so that it could bind the new mineralized surfaces and induce osteoclast apoptosis once the anti-rank ligand effect was vanished. And here's the experimental design we used. So we treated all the mice for 12 weeks and created 5 groups of treatment. The first group received anti-rank ligand for 12 weeks, once every 3 weeks with a loading dose in the first week. The second group received anti-rank ligand only for 3 weeks with a loading dose in the first week, but then we discontinued the treatment and we followed up the mice until the 12th week. And then we combined the zoledronate with the 3-week treatment of anti-rank ligand. We decided to administer zoledronate twice, 1 injection before the last of anti-rank ligand and the second injection after 21 days after the last injection of anti-rank ligand. And here we also included some other 2 control groups, the one receiving only zoledronate and the vehicle group. And here's some the X-ray analysis and results. So when we treated the mice with anti-rank ligand for the 12-week, we could see a complete reversion of the lytic lesion, and we stopped the disease progression, and we didn't see any new formation of FD lesion. But then if we stop the treatment after 3 weeks, we can see that in the 3 weeks where we give the anti-rank ligand, we can increase the bone density exactly where the lytic lesions are, but then the interruption of the drug is associated already after 1 month with the disease rebound. But then when we administer zoledronate, we can see here this clear, I don't know if that's here, these clear lytic lesions here that are first of all reverted, that we don't see them anymore in the 3 weeks of the anti-rank ligand, and then we can see here that the administration of zoledronate prevented the disease rebound, or at least delayed the disease rebound, and no new lesions developed during the treatment. And to be thorough, I included also here the radiographic results of the zoledronic acid and vehicle group. We could see some increased bone density in the zoledronate group. However, as you can see here, there is an expansion of the FD lesions into the medullary canal. And the vehicle group, of course, the disease worsened over time. And here's some histological data. So in the anti-rank ligand group, we saw the replacement of the fibrous tissue with bone tissue, and the bone is the one in pink. Then if we discontinue in the group of anti-rank ligand discontinuation, this bone is rapidly lost in favor of fibrous tissue again. But then if we inject zoledronate, we can see here that we maintain the bone tissue that is gained during the anti-rankligand treatment. And again, for the sake of completeness, the histology of zoledronic acid group and vehicle, where we see the typical features of fibrous dysplasia, but actually, if you see here, we have very giant osteoclast in the zoledronate group. So I showed you the results on the tissue pathology of the disease, but we also thought how this treatment, how this strategy could impact the clinical expression of the disease. And so that we started investigating pain in the mice. And what was really encouraging for us, not for them, was the observation that the mice had a reduced activity when they reach 4 months of age. They have abnormal gait and posture and were aggressive when handled, and all these behavioral signs are usually associated with discomfort or pain in rodents. So animals are nonverbal, and measuring pain can be very tricky. And it involves observing surrogate measures of pain or signs of animal well-being. We decided to use 3 tests, 2 assessing the spontaneous pain-like behavior of the mice, and one is the burrowing test that is based on the spontaneous ability to burrow whatever you put in the tube, and then the nesting test based on the spontaneous ability of the mouse to build a nest. The 3rd test we chose was a test assessing the nociception and was the tail flick test. This test measured the nociceptive threshold to infrared stimulus on the mouse tail. And here I'll show you the results we got. We analyzed a lot of mice. We almost reached 300 of mice. And as you can see here, these are the burrowing test results. So what we measure in the burrowing test is how much food the mouse can dig out in a 2-hour experiment or an overnight experiment, and I reported the 2 results here. So we have a clear difference between wild-type mice and the FD mice, with FD mice that showed a reduced capacity of burrowing. And then if we stratify all these results according to the age of the mice, we can see here that female mice are all FD female mice burrow less food at all ages analyzed, while male mice started having some behavioral signs of pain around 5-8 months of age. And the nesting test, similarly to what I observed in the burrowing test, showed again a clear difference between FD mice and wild-type mice. In this case, what we do is to add some shredded paper to the cage, and then we let the mouse build a nest. So the following morning, we give a score from 1 to 5 to the nest built by the mouse. And again, here, the difference is clear at all ages analyzed and in both females and males. So these 2 tests demonstrated that the mouse developed a spontaneous pain-like behavior. But what happens in the nociceptive test that we used? So here, what we do is to collect 2 measures. One is performed on the mid-tail, on 2 portions of the tail of the mouse. So one is the mid-tail and one of the tail tip. And usually, the mice that have increased nociception should report shorter latency in removing the tail. But here, what we observed, and this is something we are trying to understand now, is a delayed nociception of the mice, so a delayed nociceptive response of the mice. And this may be related to the fact that probably these mice have already pain, and so they increase their pain threshold so that we see a delayed response. In order to understand if the pain behavior was correlated in any way with the skeletal burden, we developed a tool that is based on what Dr. Collins did in 2005, that measuring the FD extension, so the FD lesion extension in the mouse. Of course, we could not do the scintigraphy in mice, but we did an X-ray, and it works very well because it's a higher score is associated with a more severe and more polyostotic disease. And also to understand if this tool was working, we correlated with age. So we have previously showed that with age, this mouse develop a more severe disease. And as you can see here, it correlates very well with the age of the mice. But then when we correlated with the pain test results, we couldn't see any difference. And this was disappointing in the first place, but then reading all the human studies, I saw that actually also human patients do not have any correlation with the skeletal disease burden. So further confirming the utility of this and the validity of this mouse model to study also the clinical expression of the disease. And then finally, I'm showing you the response of the behavioral signs of pain to the treatments that I showed you before. And when we treated the mice with the anti-rank ligand, although this is a very preliminary study and we need to add mice to this study, when we treated the mice with anti-rank ligand, we could see an improvement in the behavioral signs of pain. But then when we treated with zoledronate and the vehicle group, we saw a worsening in the behavioral signs of pain. When we combine the zoledronate and anti-rank ligand, we actually saw the best response for in the pain test, meaning that we were ameliorating bone pain behavior in these mice. So to conclude, the combination of anti-rank ligand and zoledronate can represent an effective strategy to prevent rebound after anti-rank ligand discontinuation. And we show this is the first evidence of the clinical expression of the skeletal lesions in a mouse model of FD. And we can use the fact that these mice develop bone pain, we can use that to test some therapeutic strategies that target bone pain. Our data, of course, suggest a connection between bone resorption and bone pain, according that when we inhibit with anti-rank ligand, mostly we can reduce bone pain. And the combination of zoledronate and anti-rank ligand can also be effective to treat bone pain in fibrous dysplasia. And with this, I want to thank Mara Minucci, my PI, Alessandro Corsi, and all the colleagues in lab, and thank you for your attention.
How do you know you're looking at bone pain? May I suggest an experiment? Why don't you isolate cells, FD cells, from these mice and transplant them into wild-type mice that are isogenic but don't have the gene into the bone marrow, so you can colonize a particular bone, like the femur. That will develop lesions, and then you can really start looking into see if that is being caused. The other thing you need is a conditional model where you can turn it on in other non-bone tissue and see what happens, because I think you're looking at two kinds of pain. You're looking at pain that has to do with bone, and you're looking at pain that doesn't. So that's my hunch. I might be wrong.
Well, thank you very much. I mean, you're right. I mean, well, we started analyzing also innervation of the affected bone. So I think that behavioral tests, in addition to innervation of bones, will give us some insights on that we are really developing bone pain. But absolutely, that's a great comment.
Thank you, Biagio. That was a really nice talk.